Hello, good morning, good afternoon, good evening, everybody. My name is Bryn Jones. I lead patient affairs at ViiV Healthcare, and it's a real great pleasure to welcome you to today's post-IAS community event that we're hosting here at ViiV. For those of you who don't know ViiV Healthcare, we're a company that's solely devoted to HIV, and our mission is to leave no one living with HIV behind. We're particularly excited to host this event because we're really interested and excited to think about what we can take from IAS to think about and consider this with the community. In particular, within this non-promotional post-IAS event, we're focusing on how what we heard at the conference can be translated into actions both within clinic and then at a policy level, so that we can essentially drive change with respect to health-related quality of life for people living with HIV. Now, we're joined by a really fantastic panel this evening, and they will introduce themselves in a couple of minutes. But I also want to hand you over to my colleague from ViiV Healthcare, PJ Motton-Poole. PJ is a fantastic member of our US External Affairs team. He joined ViiV with a lot of experience in HIV, working in both prevention and treatment for the prior 15 years, and with a particular focus on LGBT issues and issues for people with trans experience. And so with that, it's over to you, PJ. Looking forward to the rest of today's event. Thank you.
Thank you so much, Bryn, and thank you everyone for investing your time with us today. As mentioned before, my name is PJ Motton-Poole, Senior Manager External Affairs with ViiV Healthcare North America, and I'm excited to be your host for today's discussion on our collective future. Today, we have an amazing panel for you on unlocking our common health, where we will be reflecting on what we've seen at IAS and planning on how we can improve our future together in the new normal with HIV. Now, we all know that COVID has had a huge effect around the world, but it's also had an unprecedented impact on people living with HIV and their health-related quality of life. It's been described at IAS as the great disruptor, and for good reason, as it is something that the community at large has felt acutely. However, one unexpected outcome of the pandemic was the rapid innovation in HIV care, at a pace that we've never seen or experienced before. From integrated care, long-term planning, and differentiated service delivery, we have seen the industry move quickly, as quicker than we have in the past 18 months than ever before. This means that we're facing a watershed moment where we can truly implement the real change that it takes from what we've learned and implemented during the pandemic, along with our past experiences, to redefine and unlock the what common health is for people living with HIV. Throughout today's session, we encourage everyone to engage with us on social media using hashtag #ChangingHIVCare. The panel discussion for today will be recorded for the purposes of sharing on-demand access after the event. All community attendance will be anonymous. ViiV Healthcare has a responsibility to report any adverse events that are raised during today's session. And today's session will also include Spanish interpretation. And at this time, I'd like to pass it over to my colleague, Alejandro, who will explain how to access this widget on your desktop.
Thanks, DJ. PJ, hi everyone, it's Alejandro here. I do digital communications, and today I'm giving some instructions for those individuals who are listening to our Spanish interpretation. So I'm switching to Spanish, and here are a couple of instructions to give you a better experience. So si estás escuchando la interpretación a través de la computadora, te recomendamos que primero descargues Google Chrome, Mozilla, Firefox o Microsoft Edge. Abre el enlace de On24, silencia el reproductor del multimedia, selecciona canal de idioma y puedes disfrutar de la interpretación. Para los que no están escuchando a través del computador, tenemos la opción de recibir la interpretación vía teléfono móvil, y hay unas instrucciones que recibieron ustedes con el correo electrónico. El Which Interpretive Voice no funciona en teléfono o iPad, entonces les recomendamos seguir las instrucciones del correo que les acabamos de enviar. with that instructions, I come back to you, PJ, and I hope you have a really good experience today. Thank you so much.
Thank you so much for that, Alejandro. Please note today disclosures for today's event. Here's a glimpse of our time together today. First, I will give our esteemed panel an opportunity to introduce themselves. Then we have Professor Jeffrey Lazarus, who will be the first up to reflect on the experiences in IAS 2021 and what progress has been made in delivering health-related quality of life and how we can make it a part of the new normal. He will be speaking alongside our panelist, Dr. Antoine Ehrman, who will share his experiences and reflections on the U=U Symposium. Then we have our Voices of Community panel, including Josh Robbins, who will be highlighting key themes from the community event generated by our influencer partners, bringing together quality of life and lived experiences from the pandemic. Our additional panelists include Susan Cole-Haley, Marco Cassio, and Dr. Rageshri Dormawan. They'll also discuss additional topics and host a Q&A session where they will highlight the issues that matter most to you. Finally, to conclude today's conversation, I will be leading an interactive polling activity, which will help us to highlight and prioritize key themes from today's conversation, and then turn them into actionable opportunities. Now, without further ado, I'd like to call on our esteemed panelists to introduce themselves, starting with Susan Cole-Haley.
Hello, everyone. It's an absolute pleasure and a delight to be here today with everyone. My name's Susan Cole-Haley. I lead the community and engagement and broadcasting activities for the HIV information charity NAM AIDS Map.
Wonderful. Thank you so much for joining us today, Susan. Next, we have Professor Jeffrey Lazarus.
Thank you very much, PJ. I'm Jeff Lazarus, a professor at the Barcelona Institute for Global Health. I'm here in Spain. I'm also the co-chair of the HIV Outcomes Initiative that I'll be explaining in a few moments. And previously, I worked at the World Health Organization and the Global Fund. Excited to be here.
Wonderful. Thank you, Professor Lazarus. Next, we have from the Community Voices panel, Mr. Josh Robbins.
Hello, everyone. I'm Josh Robbins. I live in Nashville. I believe in convergence, and so the lines kind of dissolve a little bit. I'm an HIV activist, but I also own a niche marketing company in Nashville that works with pharmaceutical companies on how to best engage with patients. And then finally, I also created recently the Health Advocate Day online. So it's hashtag Health Advocate Day. And it is a day that celebrates chronic health condition advocates of all health conditions in one 24-hour period each year.
Wonderful. Thank you so much, Josh, and we're excited to have you. Next, we have community advocate Mario Cassio.
Hello, everyone. My name is Mario Cassio. I come from Italy, and I am currently the Program Chair for Quality of Life of the European AIDS Treatment Group. And my role within the organization actually reflects my interests as an activist on topics such as aging with HIV, novel approaches to the long-term management of HIV, and quality of life as a core element of all aspects of HIV care. I am also a person who has been living with HIV for over 35 years.
Wonderful. Thank you so much, Mario. Next up, we have Dr. Rageshri Dormawan.
Hello there. My name's Rageshri Dormawan. Thanks so much for the invite to take part in this exciting panel today. So my name's Rageshri. I'm a doctor of HIV based in London in the UK. And I do inpatient and outpatient care of people living with HIV. And I'm also a researcher, and my research and advocacy concentrates on health inequalities, particularly to do with gender and race.
Wonderful. Thank you so much. And we're excited to have you here today. And last but not least, we have Dr. Antoine Erman.
Hello, everyone. My name is Anton Yeremin. I'm HIV clinician and infectious disease clinician based in Moscow, Russia. I work at Moscow Regional Center for AIDS Care and Prevention. And besides that, I work at one of the biggest NGO in Russia called AIDS Center Foundation, where I serve as a medical director. I'm very excited to be here, and hopefully we'll have a great event.
Wonderful. We're excited to have you today as well. Now we will progress to our objectives for our time today. And thank you again to all of our panelists for lending your time and expertise today. For today's conversation, our objectives include hearing findings from the International AIDS Society Conference 2021 and opinions from our expert panel, and align and discuss key priorities and actions going forward to improve the health-related quality of life for people living with HIV. So without further ado, here's Professor Jeffrey Lazarus with our first topic on making health-related quality of life a part of the new normal. Over to you, Professor Lazarus.
Great, thank you so much, PJ. You know, the term "the new normal" at times disturbing because, I mean, what are we really talking about? How long is this normal going to last? Is it the normal we want? When we were talking about these issues at the HIV Outcomes Symposium at the International AIDS Society Conference, which seems like it was a million years ago, but it was really just last week, and so much has happened since then. You know, we were talking about, well, one thing that's really changed is the understanding of the importance of health-related quality of life, or what some people will simply call quality of life. During the pandemic, everyone has suffered, and quality of life has suffered in so many different ways. So while we were at this symposium for HIV outcomes, and I mentioned in the introduction, I'm the co-chair along with Jane Anderson and Nikos Teres. Jane, who's a clinician in London, and Nikos Teres, who's the former chair of the European AIDS Treatment Group, where Mario sits. We looked at the wider implications of related quality of life and this intersection of COVID-19, and in this case, we specifically focused on HIV. And one of the challenges we've had with HRQOL or QOL is really getting it onto policymakers' agenda, even getting it onto clinicians' agendas. You know, we've been racing to address the 390s. We're doing very well. We haven't reached the 390s. In all countries around the world, or countries where we have reached the 390s, we haven't reached it for all populations. Quality of life on what, but that's listening to the population. So going back to the nothing for us without us, and this was the need to measure and bring more patient-reported outcomes, PROs, or patient-reported outcome measures, PROMs, into focus. So one of the issues that I raised during that symposium were what I think are three key issues related to health-related quality of life. I think when you talk with clinicians, they'll often mention the importance of comorbidities and having more than one comorbidity, so multi-morbidity, and making sure health systems are really reoriented and focused on addressing people and not just viruses, infections, or individual diseases and conditions. As I mentioned, the issue of self-reported HRQOL. We need to listen to the population. We need to do this systematically. So we need to understand how the population of people living with HIV as a whole in a particular setting, be it a city, region, or country, are doing in terms of health-related quality of life, but also as individuals, so clinicians can react to that and provide better, more person-centered care. And then the other issue that has simply dogged us for decades, which is stigma and discrimination. Stigma that's so challenging to overcome and address, although there are proven interventions, that evidence-based interventions that can work, and discrimination, so laws and regulations that are on the books and that should not be, that discriminate directly against people living with HIV. This could be getting a mortgage, this could be getting a particular job, it could be discrimination that's felt at the individual level when even within the healthcare you might be denied care or provided with worse care because you're living with HIV. So multimorbidities, self-reported HRQOL, PROMs, stigma, and discrimination are the core issues, I think, that we really need to address to get HRQOL onto the agenda and to make sure it stays on the agenda. So to reorient health systems to deliver care, even beyond viral suppression, so beyond the third 90, we need to adopt a long-term approach. And that's why it was so great to see in the new UNAIDS strategy that they're looking, well, both longer in terms of years to reach the end of HIV, but also longer in terms of going beyond viral suppression and addressing those important issues that I just mentioned, like accounting for comorbidities. So, of course, we know that individual clinicians will follow their guidelines. They should be following their guidelines, check people for the comorbidities that they might have. So what I was saying was that to reorient health systems to deliver care beyond viral suppression, we need to adopt that long-term approach, which means also tracking the comorbidities that people living with HIV might have, and to become more patient-centric or really person-centric, to make sure the health system is working for the person and not just working the way it always works or working around that individual. And some of the things we can do concretely are to reach a consensus on what do we mean by quality of life for people living with HIV? What do we mean by health-related quality of life, and what tools should we use to measure it? How can we break down those healthcare silos so that people aren't, the system's not working in parallel and making the individual move, but actually coming to the individual through multidisciplinary teams and other tools where we can have co-located services. It's incredibly important to develop accurate metrics, and the new UNAIDS guide and WHO work is helping us along the way, but we still aren't doing a good job of measuring what the community reports about their health-related quality of life, what discrimination or discriminatory laws are on the books and in practice, and as I mentioned, what comorbidities people living with HIV have. We have good cohort studies that do that, but the health systems and the agencies in those systems responsible for monitoring really need to do that. And to do all of this, of course, we need to continue to intricately involve the community. The community needs to be involved in developing those metrics and agreeing on the tools that will measure how, in fact, they are listened to. So my final comments are really, how do we bring this up to the level of policymakers to see the value of quality of life for people living with HIV in a strained healthcare system? And I think we need to leverage the COVID-19 pandemic to be able to say, look, quality of life has become the central issue. Everyone suffered poor quality of life during the pandemic, but people living with HIV have lived a long time poor quality of life because of the historical discrimination and stigma and not being listened to that's heard in so many countries. And then how do we shift policymakers who are in pandemic mode? And here in Spain, they're in high mode, in the UK, in many countries around the world where the COVID-19 pandemic is still raging. We need to look at the innovations that can come into place to make for a better recovery for everyone. And I won't go into detail, but these are issues like digital health interventions and telemedicine. How can we develop that, making sure we leave nobody behind? How can we move care into the community, as we saw hospitals and clinics collapsing, even in high-income countries during the pandemic? It raised the issue of community-based care, something we've been arguing for in the field of HIV for so long. Now we need to start making this a permanent part of our reality, or a part of our new normal. So PJ, back to you. And sorry, I checked out there with the video, but I'm glad you could hear me the whole time.
Perfect. Thank you so much, Professor Lazarus, for your insights and for your questions that I think that we could pose to the entire HIV community around how we really create a more integrated system of care that is really centered around community needs and voices. I wanted to ask one of our panelists, Mario Cascio, what do you think that it would take for countries to systematically monitor the issues that Professor Lazarus discussed?
Thank you, PJ. Well, the way I see it, there's often a lack at national level of strategies and coordination for the collection of data, and very often insufficient funds are allocated to research. In many countries, there's also a lack in technology infrastructure, allowing the flow and collection of data through digital health records. But not only. What I think is important is to understand the role that clinical societies and community can play together in this. And I think cohorts can represent a great opportunity in moving forward. In Italy, for example, where we have the ICONA cohort, which is one of the oldest European cohorts and well known at international level, there's a widely accepted idea of the added value that community can bring in the area of research. And there's an idea of creating a specific group within the cohorts on studies related to quality of life, actively engaging community members in defining specific indicators reflecting the needs of people living with HIV. So collecting the right data, in fact, will be crucial in order to support decision-making about how the long-term health-related needs of people living with HIV can best be met. To sum it up, I think we have to raise the profile with our policymakers of the need for better monitoring, provide the evidence, and engage community more in research on health-related quality of life.
Wonderful. Thank you so much, Mario, for your insights. Without further ado, we'd also like to introduce Dr. Anton Ehrman to share some of his insights on the U=U Symposium. Over to you, Dr. Ehrman.
Thank you so much, PJ. It's a great pleasure to be a part of today's meeting, and after Professor Lazarus highlighted the importance of including the quality of life into the agenda of HIV care, I would like to share my thoughts on how to put this into practice. Sorry. Yes. As a clinician, I oftentimes have 10-15 minutes appointments when patient goes after patients, and sometimes I catch myself focusing on telling persons with HIV something like, okay, your viral load is undetectable, your T cells are those, our tests are okay, and so on and so on and so on. But, you know, then I think about it from the perspective of the person taking the medication. It's, okay, I know my numbers are good. I know I feel good, but how does this information really benefit me? How does it really makes me or my life better? And I think these are the questions we should constantly ask to set this a new normal in HIV care and to start with the quality of life as a key measure of successful HIV treatment. Talking about measuring system, unlike the viral load or immune status, the quality of life is not that easy to measure, but the only solution, as Mario said, is to collect scientific data. There's a study called the Positive Perspectives Wave 2, which was a community-based survey that has involved almost 2,400 persons living with HIV from around the world and covered many different areas of patient-reported outcomes. And the quality of life was one of the main topic and one of the main goal to measure this in the studies. So participants were asked to quantify their overall physical, mental, and sexual health and satisfaction with the current HIV treatment. One of the key areas of this study which were discussed in the Positive Perspective 2 study was a concept of U=U. I'm pretty sure that most of you are fully aware of U=U. It's one of the most significant scientific developments and a great example of collaboration between researchers and the community advocates. The U=U movement recently celebrated 5th anniversary, so we have known for 5 years that the people living with HIV who are on treatment and have an undetectable viral load cannot transmit HIV to their sexual partners. It was based on the 4, maybe more, large studies that encompassed more than 100,000 unprotected sex acts between serodiscordant partners. And of course, its transformative message, which is, as said, affirms that now people living with HIV are not the disease vectors and can be touched and loved. Of course, it's supported by many international organizations such as WHO, CDC, PEPFAR, and so on. But going back to the results of the Positive Perspectives 2 study, as you can see on the slide, we have data which show that those individuals that said, yes, I had a conversation with my healthcare provider about U=U, were more likely to report optimal sexual, mental, overall health. Also, they reported fewer misdosed they were more comfortable with sharing their HIV status, and they reported better viral suppression. So now we know that U equals U is not just a message to discuss, a nice message to discuss with people living with HIV, because we have evidence that U equals U has a greater impact. It can transform sexual and reproductive health, reduce HIV-related stigma, and motivate people to be adherent to treatment. I think it's very important to measure this and to see how the one movement, one research can change the life of so many people. And my reflections on this could be the situation that I faced in Russia, because we have a robust data behind U equals U and its importance, but we are still facing lack of confidence in the message, especially among healthcare providers. According to the same study, the Positive Perspective 2 study, there was a demographic difference around the world as to how often the conversation about U equals U occurred. For example, in Switzerland, 87% of participants received information about U equals U from their healthcare provider. And for example, in my country, Russia, that was only 46%. And this represents the reality. Personally, I often have conversations with Russian doctors and other healthcare providers who say that, okay, yes, I partly agree with U equals U, but I'm not fully convinced. Tell me something because I have yes, but, and then they continue their phrase. So this situation requires new strategies that go beyond the science behind the U equals U to consider local clinical and social environments and to increase the effectiveness of the message. That's why I was very inspired so much by the symposium called Scaling Up U equals U at the IAS conference, where brilliant community advocates and specialists shared many cases and case studies on how to raise awareness and implement U equals U into HIV care. At my organization, which is AIDS Center Foundation, non-governmental organization where I also work, we have sent several important proposals to Russian Ministry of Health on the optimization of clinical guidelines. We focused on the principle of U equals U and the doctor-patient communication. The response was quite generic, mentioning that officials will take into consideration our position and will focus on the priority of the patient's interests in the development of documents related to HIV care. I wouldn't call this a success story, but we won't stop on that, and we will continue this work. If we will follow the science, we'll hear the people living with HIV voices, changes will come. Thank you so much, and we'll proceed to you, PJ.
Wonderful. Thank you so much, Dr. Arman. I really love the sentiment around U equals U is transformative for people living with HIV, affirming people as whole beings worthy of love and affection and not vectors for disease. Thank you again so much. So I am extremely delighted and excited to introduce our Voices of Community section, and we'll start this panel off with HIV activist and phenomenal speaker who I'm always excited to share space with, Mr. Josh Robbins.
Thank you so much. So this is, for me, this is pretty exciting. There's my photo, y'all. But moving on, I was really excited to be able to partner with ViiV during IAS because we wanted to ask really some important questions about quality of life and the experiences of people that are living with the virus during the pandemic. And so we've got some insights that I want to share with you. The first question, it's in the phone, and you may not be able to see them, but we asked the question, how has your HIV care, has it gotten better or worse during the pandemic? And 58% said better, 42% said worse. An additional question is, do you think the quality of life would change for good or bad if virtual appointments were here to stay? There are a lot of people like myself that virtual appointments have really helped see new people. For example, I was able to see 2 dermatologists recently. If that would have been in person, there was a 6-month wait. And so the response from the community was that it would be good if virtual appointments were here to stay at 81%, and then around just under 20% bad. And then how has your HIV care during the pandemic changed? So better, worse, or no change? So about 60% or so states that there's no change, and then kind of going from there. So we see also, if you just see the no change, you're like, oh, well, we're not really sure how to yeah, there could be multiple reasons for that. What we see from the other two choices is that there has been movement in some level, whether somebody thinks it's worse or better. Now, with that, the votes were small, but we've got some comments that were interesting. So Brady Exxon Morris, one of my friends actually from Nashville, said that he reclaimed a lot of his personal time during the pandemic that is usually spent staying in care. So renewing his Ryan White coverage was the easiest it's ever been. And he also said that he's experienced faster response times from his case managers and being able to have longer, better conversations with them. So the communication is really important. So that's reflections from the community. We had an interesting discussion as well, because how do you define quality of life? It becomes as difficult at times to define this as it is to define stigma, for example. And so maybe I should just talk a little bit on my perspective of quality of life. Patient centricity is a buzzword, and we've heard that a lot. And some patients, including myself, feel that can be lip service, because we know that it is. So how does that translate from knowledge into action? And here's what I mean by that. It requires people, patients particularly, to be very selfish when they're inside the doctor's office. It has to be about the individual, yourself, when you're in the doctor's office. And so that community-wide or community healthcare idea and consumption is important for the policy level, but when you're thinking about action and the individual, then making sure that quality of life on the individual's level becomes really, really important. And, I was somebody that didn't realize I could fire my doctor, right? Quality of life became really an important part of my care. And I had a physician who maybe didn't think that as much. And so it was, I had to make a selfish decision early on in my care to be able to say that quality of life is something that's really important. And we found those insights to be similar with community members as well. I don't want to stop without taking note of the U=U at 5 birthday celebration that happened during IAS. And it was an amazing just celebration from all over the world of how far the activist-led, driven campaign and movement has come in 5 years. And so just a shout out to Prevention Access Campaign and Bruce Richmond and the whole team over there. And that live stream was really good. So you got to check the replays out. Finally, care for HIV must be designed with people living with that are living with the condition. And so the care, there's a saying that nothing for us without us in the HIV space. And that certainly continues to be true when we are looking at designing what that care should be for, this population. And so with that, I thank y'all so much. And PJ, back to you.
Perfect. Thank you so much, Josh. Once again, nothing for us without us. # changing HIV care. If you are joining us, please engage with us online with the # changing HIV care. We have some phenomenal speakers that have shared some insights, and we have a few more, even more phenomenal speakers. I wanted to point out that we had Yana Panfilova, a Ukrainian activist, who has been working with working with ViiV Healthcare to capture some of the insights during IAS. Dr. Ehrman, could you share some of her insights or perspectives with regards to some of the things that she shared or captured during the IAS experience?
Yes, of course. We've discussed with Jana many various aspects regarding HIV and the public health in general. And what we mentioned and what we see both in Ukraine and Russia and many other countries from the Eastern Europe and Central Asia, that there's a lack of awareness regarding many things about HIV, about vaccination, and that leads to different problems like vaccine hesitancy, for example. When, for example, GPs are not fully informed about the vaccination among people living with HIV, they insist on a documented permission for a COVID vaccine from the infectious disease specialist for safety reasons, as they say. Or at the same time, some people sharing their horror stories and about vaccination, and anti-vaxxer moods easily grow on this soil. So for many people, the awareness is the key, and for us as community representatives or doctors or advocates from the HIV response sector, we really need to discuss these topics and to discuss this publicly, because only ways like this can change the situation and change the public attitude to different topics such as vaccination or HIV.
Wonderful. Thank you so much, Dr. Armin, and thank you, Jana, for capturing those insights for us. Next, we'd like to introduce our panel perspectives section, and we're going to start this section off with the lovely Susan Cole-Haley. Susan, over to you.
Hi, thank you so much for the wonderful introduction. And wow, everything everyone shared so far has been brilliant. This is an absolutely brilliant session. If you're enjoying it, do please tweet about it. I delivered the keynote address of the conference, How Do We Continue to Unite Policy, Science and Activism in an Increasingly Fragmented World? As someone living with HIV, the reason I'm still alive is because of the tremendous advances in science that's given us an arsenal of tools to tackle the HIV pandemic. HIV is no longer a death sentence, and with effective treatment, people with HIV can expect to live as long as anyone else, and we can't pass HIV on to our sexual partners. So high five to the U=U movement 5 years last week. And the incredible progress we're seeing today was very much reflected in discussions at IAS 2021, such as studies on long-acting injectable treatment. But many of the advances that we're seeing would not be possible without the tireless activism, often led by people with HIV, combined with policies that follow the science. Today, people with HIV are leading the fight to ensure we receive person-centered care that recognizes the huge importance of quality of life, not just looking at viral suppression as a measurement of success. We are so much more than our viral loads and CD4 counts. Today, we're living in an increasingly fragmented world, fueled by inequalities, including between countries and indeed within them. The COVID-19 pandemic has shone a light on existing health inequalities and in some cases have made them worse. Evidence shows us clearly that inequalities are driving the HIV pandemic. As the UN global strategy sets out, we have to end inequalities to end AIDS. But I think we need to go beyond that. We also need to look to end inequalities so all people not merely survive, but thrive with HIV. And looking at quality of life is absolutely key. I know that Dr. Rageshri Dharawan is going to be talking about her hugely important study that demonstrates that racially minoritized people with HIV in the UK face significant barriers to testing, taking treatment, and staying engaged with care. But what she was able to evidence were stories that I've been hearing from people of color for some time through my community engagement work for NAM AIDS Map. Black women in particular have been sharing with me that when we report side effects or talk about our concerns, often they're not taken seriously or we're not believed. I've heard of women talking to their doctor about worries about weight gain, but being told that Black women just like to be big, or the treatment is working, so just stick with it. I know people who are skipping doses to try to cope with side effects. Living with unwanted side effects from HIV treatment can have a huge impact on quality of life. I've certainly been hearing about quality of life relating to people of color and women being impacted during the pandemic, very often fueled by inequalities. I've been really fortunate that I've been able to work from home, and I've had telephone consultations with my HIV consultant, and it's been very much in the privacy of my own home. However, there have been significantly different stories for a lot of people. I spoke to one person who's an asylum seeker living in a shared house with other people, none of whom know about his status. And it's been incredibly difficult for him to talk about his health with his doctor on the telephone. And it's not just about privacy. There's a real digital divide. I know people who don't have Wi-Fi or data, or their only device is one mobile phone shared between everyone in the household. And I think emotional well-being has been significantly affected by the COVID-19 pandemic. For women, often we're juggling childcare and other healthcare and family responsibilities. And we really need to have much more of a discussion about that. I mean, it seems that remote consultations will be the new normal, but I think it's really important that this isn't the only option, as it won't work well for everyone. So I think, as everyone is saying, that it's really important that the voices of people living with HIV are very much at the center of our care. And just to repeat, nothing about us without us. Thanks very much.
Wonderful. And thank you so much, Susan. So many great jewels with what you shared with us. Next, we want to have Mr. Mario Cascio, a community advocate. Mario, over to you.
Thank you, PJ. I'll start talking about COVID, of course, just for a change, and on how COVID crisis has certainly reopened the debate on current HIV care. It has highlighted the inadequacy of existing approaches in addressing many of the unmet needs of people. I mean, during the pandemic, virtual platforms have become both a necessity and an opportunity, accelerating the ongoing debate on how technology can be an effective tool in health management. But at the same time, we must also consider the risk of leaving behind the most vulnerable people who are unprepared to use internet or online services, including those from groups with low health literacy and low socioeconomic status, and others, like Susan pointed out, who for other personal reasons may not be comfortable in engaging in virtual conversations. But how can the use of technology fit into the new normal? What are we gaining and what are we losing? I think technology can definitely move us one step forward towards the integration of services through easily accessible virtual consultations, also with other specialists from other medical areas, like Josh mentioned before, saying he was able to virtually see his dermatologist twice. And this will increasingly be needed considering the increasing burden of multimorbidity. But at the same time, this may pose challenges, as Richard Harding pointed out at IAS, regarding confidentiality issues and the flow of data between specialists. And let's keep in mind that while this may be convenient and much appreciated by most people, let's make sure we're not leaving anyone behind. Many speakers at many sessions at IAS have highlighted the potential of patient-reported outcome measures, which are tools in the form of questionnaires able to capture the patient experience in many domains, and which have the potential of enabling and facilitating communication between patients and healthcare professionals, offering our doctors the opportunity of knowing their patients better, what matters to them most, what barriers they face in their daily lives and in their healthcare, and offers patients an opportunity to openly discuss in the course of consultations those issues and concerns which for many reasons they are often unable to express during consultations, empowering them to actively take part in the conversation, in joint priority setting, and in shared decision-making on interventions to bring forward. If widely used, patient-reported outcomes can indeed represent a key element of patient-centered care. But here again, let's make sure this opportunity doesn't leave anyone behind. The pandemic also seems to have brought us one step backwards in reaching our UNAIDS targets, but also on the so-called 4-90, which is that of ensuring a good health-related quality of life to all people living with HIV. People living with HIV have been impacted by COVID in their physical, mental, emotional, and social spheres, with unclear consequences in the long term. Service disruptions and continuity of care in times of emergency have led to a distancing from care, with many people adapting to fewer visits and fewer contacts with clinics, with the risk that what we've lost to COVID may somehow become the new normal. And there has certainly been an impact on comorbidities, with the limitation of screening services and specialist consultations, which may lead to undiagnosed, untreated morbidities, which can be particularly relevant for older people. And as we move towards a new normal, the concept of healthy aging and quality of life should guide us all in our daily work, and at all levels, at policy level, at clinical level, and at community level. And finally, we know that people living with HIV are disproportionately affected by mental health problems, which are often underestimated in clinical practice. Problems often leading to depression, social isolation, and loneliness, which in turn may result in poorer health outcomes and poorer quality of life. And COVID has certainly additionally destabilized people living with HIV in many ways. A recently published report from the survey conducted by the EATG across Europe has highlighted a concerning burden of mental health issues among people living with HIV, and at the same time, a limited access to support services. Community-based organizations, through peer support and other services, have historically played an important role in supporting people suffering from depression, loneliness, and internalized stigma, and can play an even more important role in the future through the specific training of lay workers, enabling them to put in place a first approach triage with a structured referral system for diversified specialist interventions. Thank you.
Thank you so much, Mario. Just a reminder to our audience, you can submit questions in the Q&A box for the audience or for the panelists to address in the next section. Also, please continue to engage with us on social media using hashtag #ChangingHIVCare. Next, and finally, but certainly not least, we have, let's welcome Dr. Rageshri Dharmawan, who is a sexual health and HIV consultant. Dr. Dharmawan, over to you.
Thanks so much, PJ. So I was really excited to be invited to take part in this event because it's so great that we're talking about quality of life and we're not just talking about clinical outcomes such as viral suppression. So thanks a lot, ViiV, for holding this event. So during IAS, I think it was particularly good for me to see so many sessions focusing on health inequalities in HIV and beyond, particularly looking at the social determinants of health, as we know as much of health is determined before people reach clinic. I was lucky to do a session on the first day of IAS with Jeff. And during this, we discussed in detail with regards to both HIV and COVID, the social determinants of health. And we also talked about the underlying factors behind them. So these are systems of oppression, such as structural racism and sexism, homophobia and transphobia, for example. And we talked about how we need to overcome these as a society to ensure health equity for all. And I wasn't actually planning to talk about my study, but as Susan mentioned it, I will highlight it. So with colleagues, we found that brown and black people in the UK who are heterosexual face poorer HIV clinical outcomes than white people. And we felt that this really showed that they face significant structural barriers to testing, taking medication regularly and staying engaged in care. So essentially they are experiencing the effects of structural racism in many aspects of their life, which are affecting their HIV clinical outcomes. So what can we do to improve quality of life? I think as we move forward, it's important that we monitor how some of the service changes that we've had to make due to COVID affect those people most affected by structural barriers to care, such as those people who live in poverty, those in key populations. For example, monitoring the shift to telemedicine. We know that it's really suited some people, but other people less so. And we need to ensure that we have a variety of ways in which people can access care, as one size does not fit all. We can use patient-reported outcome measures, for example, to do this. We can also take a more holistic approach to ensure we're asking people about their lives outside of clinic. Do they have the money to afford food? Can they afford to come to clinic? Are they experiencing domestic violence? And once we've asked about these issues, we must ensure that we have the pathways to refer people to organisations that can help, or even try and provide help in-house. So, for example, we're very lucky in my clinic to have a social worker who can signpost people to the right places to get the help they need. There was also a lot of discussion at IAS on managing comorbidities as people age. And I think it's really important that we take advantage of the service changes we've made due to COVID to look at how we can incorporate monitoring for these comorbidities and making sure people are aging well. So, for example, things that we can do in clinic, we can look at how we can better integrate care with other services. So, for example, incorporating care with mental health and with peer support, working with our elderly care colleagues. We need to look at how we can deliver more care in the community. Could we use primary care better? Could we have clinics based in the community? And of course, we need to involve the HIV community in any services that we do make right from the beginning. And I think as people get older, they will be seeing more healthcare professionals from other specialties. So it's really on us to make sure that we educate people, healthcare professionals in other specialties, about HIV and how it is now. For example, we need to make sure they know about U equals U. And this is important because we need to make sure that people living with HIV don't experience so much stigma or discrimination within the healthcare system from other specialties. I was also really excited at IAS about the new ways of delivering HIV treatment and prevention. So these included, for example, long-acting oral and injectable treatments. And what this means really is that we have more choices available in the future so that we can really truly achieve individualized care for each person. People can express a preference for what kind of treatment would suit them better. I think these things together will help improve quality of life and get us closer to health equity for people living with HIV globally. And finally, I just want to reflect on the effect of COVID-19 on healthcare professionals working in HIV. I was one of many who were redeployed from my day job in the HIV clinic to work on the COVID wards. And as I'm sure everyone is aware, the COVID pandemic has been challenging for healthcare professionals all around the world, as it has been with everyone else. There's been dealing with a new disease and also experiencing the grief of seeing so many people dying or very unwell, and not only patients, but also colleagues and family. I think going forwards in the pandemic, it's really important that we care for the carers, so ensuring equitable access to COVID vaccines, PPE, so protective clothing, and making sure that healthcare staff get adequate rest and remuneration for their work so that we can provide better care to people living with HIV as we go forwards. So that's it from me. Thank you very much for listening, and just handing back to you, PJ.
Wonderful. Thank you so much, Rageshri. We will transition now to our Q&A section. And thank you so much to all of our panelists for your insights and for sharing all of your knowledge and reflections from IAS 2021. If you have not already, please submit your questions in the Q&A box, and we will assign them to a panelist here in the live Q&A section. So we have a few questions that have been submitted already. The first one reads, I agree that monitoring of health-related quality of life is very important in order to have an increased focus on it. I think one of the key challenges is how best to do that, preferably in an actionable way. Does the panel have any advice on that? I think I'll pass that question over to Professor Jeffrey Lazarus.
In order to get countries to monitor something like HRQOL, we really need to require it from international monitoring bodies. So this includes UNAIDS, this includes the World Health Organization, it may even include the Global Fund or PEPFAR or other international donors. Here in Europe, it would mean the European Center for Disease Control, the specialized agency of the European Commission. So we need to drive it from the top down, and at the same time we need to drive it from the bottom up at the national level, where groups of people living with HIV, advocacy groups, even clinicians and other interested stakeholders need to push the monitoring bodies to take on this issue and explain and emphasize why it's so important.
Wonderful, thank you so much. Does anybody else on the panel have a reflection to that question? All right, perfect. So we're going to move on to our next question. And it reads, how does quality of life, or U equals U, contribute to the goal of ending AIDS by 2030? Let's pass this question over to Dr. Ehrman.
Yes, as I mentioned before in my presentation, we see how easily the only one like sentence and the scientific data behind it can change the life of millions, because it changes a person's life, because every person now can have normal sexual, reproductive health and mental health and related to health issues can be solved by this. Also, it's a great motivator for the public authorities, because if you know that U equals U, if a person is uninfectious in a way, so you can just give treatment to everyone, providing universal access to treatment. And this is the main goal to end AIDS, because if everyone receives treatment, there is no AIDS. And probably this is main 2 points. Besides that, it's very important that every person has universal access to the treatment. And I think this is the topic we should really discuss, because not every person, for example, in my country can receive treatment. For example, if we talk about migrants, and it's a situation which is really very different for some other regions and countries. And I feel that it's also the topic we should discuss later.
Wonderful. Thank you so much, Dr. Arman. Our next question is, telemedicine has the risk of leaving people behind and may make it harder for HCPs to identify people living with HIV's challenges. Is telemedicine compatible with improving health-related quality of life? Professor Lazarus, I'm sorry.
It's okay. It's absolutely compatible, but you're right. Or the person who asked the question is, we risk increasing the digital divide if we move too quickly forward with digital health interventions and telemedicine. We need to consider that not everyone will have a good connection. I don't even have a good connection right now. Not everyone will have the privacy to be able to discuss medical issues, because they live with family, friends, in crowded conditions. They may be in a shelter. So it's not always easy to have that kind of consultation where you're kind of on a video shouting into a screen, a little bit like what I'm doing right now. But wouldn't want to be doing that if it was about, my health condition. So I think, as we move forward, we'll have to move stepwise. So for some populations, we can move rather quickly, and that will probably happen in high-income countries, but it also might happen in low-income countries where it's difficult to reach a hospital, a clinic, or a doctor or a nurse. Telemedicine, it's already been shown, it's been a fantastic solution so that you can have the care you need without having to take that kind of challenging travel.
So our next question is, what practical steps can be taken in the clinical setting to enable people living with HIV to be more empowered in their care? And any of our panelists can jump in here if you'd like. Again, the question is, what practical steps can be taken in the clinical setting to enable people living with HIV to be more empowered in their care?
So I think there's a few things, both on behalf of the people working in clinic and for people living with HIV who are attending the clinic. So I think healthcare workers need to be aware of the power imbalances that we have with people who are coming into our clinic. So being aware that how we act and how welcoming we are as a clinic and as a service in general may impact on what people feel they are able to speak to us about. So just being aware of that, trying to work with that is important. Things that I often tell patients is that, I've been a patient myself. I know what it's like to go and see a doctor, and all the things that you've thought about before you get into clinic, you suddenly forget because you're in the clinic room and, you've forgotten where you were, all the things you wanted to say. So things that can be useful are making a list. So making a list of all the issues that you want to cover. I think this is probably easier pre-COVID, but thinking if you're not able to talk about something, perhaps bringing someone with you to help advocate for you. And this could happen by telemedicine as well. If you've got someone with you, for example, who can help advocate for you. And I think it's also important to think about if you're not getting what you want out of the consultation, don't be afraid to ask for a second opinion. We don't mind being, that if you want to ask someone else for a second opinion, it's not a big personal thing to us. So really just trying to ensure that you get what you need. Thanks.
Absolutely. It's extremely important to make sure that you're getting what you need. Mario, did you have a response as well?
Yeah, I could just add to this the fact that, okay, as I was mentioning before when I was in my presentation, I think that patient-reported outcomes could be a way, a tool which can actually, let's say, address this fact of the imbalance between, power imbalance in the therapeutic relationship. I mean, it's a way also of opening up communication. It's a way of understanding your patients better, but at the same time, it's also a way of empowering patients, people, because in these conversations, a lot of topics will come up, and so it will be much more easier for to let's say, communicate many aspects regarding the care of the single individual, and little by little, I think this will be very empowering for people.
Absolutely. Our next question is, do you see reimbursement shifting the value base in a particular outcome? Do you see reimbursement shifting the value base in particular outcomes from PROS data? Professor Lazarus?
Sorry. So I think there's that possibility that that as value-based medicine, it takes off and becomes increasingly considered, that PROS can play an important role there. I mean, you have to remember, PROS can be used in different ways. They can be used for larger studies to look at how an entire hospital or clinic or population of people living with HIV are doing. I mean, at the country hospital level, or at the individual level. So I think it's going to be challenging. I think it's going to take a while. When the ECDC measured across Europe how many countries were, are looking at self-reported health-related quality of life in 53, WHO European region countries, I think only 5 were, and they had only done it, once in the last few years. So we have a long way to go, but we need to look for every avenue possible to make sure PROS get on the agenda and get, aren't just sort of our research projects at universities and in collaboration with clinicians, but that they become embedded in the response to ending the HIV epidemic.
Thank you so much for that response. Our next question is, how can we work to build health-related quality of life in lower income, higher HIV prevalence countries where resources are stretched? Again, that's how can we work to, I'm sorry. I think we heard Susan first, and then we'll have Professor Lazarus.
Please.
Hi. Yeah, thanks very much. I think this is such an important question. Yesterday, I hosted a IAS feedback session, AIDS Map Live, and we were talking about virtual care. And one of our panelists who lived in Kenya said that it's really funny that you're talking about some of the challenges with virtual care when so many people in other countries are struggling to even get their medication. So I think we need to be really conscious of the huge inequalities in terms of the type of care that people are actually receiving. So over to you, Jeff, in terms of solutions for this.
Yeah, I think you really covered it. This is going to be such a challenging issue in low income settings where we're still facing the challenge of reaching the 390s.
Thank you guys so much for your responses there, and thank you to our audience for engaging with us during our Q&A section. Great questions and great insights from our panelists. So we've heard a variety of insights and opinions from our panel, and of course, there are some very important and valuable initiatives that are happening. But to make real change, we need to focus that in and on community. And so as mentioned at the top of our conversation, we have the opportunity to prioritize the key findings from today's discussion. First, I'll read some of those key findings that were previously submitted by our panel, and then I will launch a poll and have you, the audience, give an opportunity to respond with your top two priorities. So the first section is going to be, we've asked our panel experts to share the top priorities for action in policy and in clinic. And so the first portion is going to be in policy. I'm going to read each one of them, and then I will launch the poll in which you would have an opportunity to respond. So A, better monitoring of comorbidities at healthcare system level. B, develop a consensus on a metric for measuring quality of life. C, ensure healthcare providers and people living with HIV are made aware of U equals U. D, educate other professionals, for example, teachers, law enforcement, and others to reduce stigma. E, increase equity in healthcare for people living with HIV. And F, develop a wider variety of ways to access HIV testing to ensure early diagnosis. So the question is, which policy actions will make the biggest impact to quality of life for people living with HIV? Please pick two. And while we are waiting on responses from the audience, we are going to prepare our panel to respond to this question as well. Which policy actions will make the biggest impact for the quality of life for people living with HIV? Once again, please respond with your top two responses. So I see we have some responses coming in with developing a consensus on a metric for measuring quality of life in the lead. We also have ensuring healthcare providers and people living with HIV are made aware of U equals U following. And then following behind those, we have better monitoring of comorbidities at a healthcare system level and educate other professionals, for example, teachers, lawyers, and law enforcement on to reduce stigma. I want to hear a little bit from our panel, starting with Dr. Ehrman. Which policy actions will make a better impact or the biggest impact for quality of life for people living with HIV?
From my opinion, I would say that I would choose two, which is develop a consensus on a metric for measuring quality of life. And the second one is to ensure that healthcare providers and people living with HIV are made aware of U equals U. And I don't know if we are ready to discuss the specific one, or are we still waiting until the results?
No, we actually have all of the results in with develop a consensus on the metric for measuring quality of life in the lead. So you can go ahead and discuss some of the specific.
So regarding the consensus on a metric for measuring the quality of life, I would say that it would be great. It would be a dream to create such a universal tool which can be applied in different settings in different income countries, and to just use it to see the quality of life, to check the quality of life of people living with HIV. I know this is a very hard task and the goal is very long, but it's very important to have something universal, which we can use in different settings and which we can apply to different situations. That's why it's so important to have like something in common and to compare, to see the differences and to see what's going on regarding the quality of life of our patients.
Wonderful. Thank you so much. Next, let's hear from Professor Lazarus.
Thanks, PJ, and thanks, Anton. I mean, it's so important to measure quality of life, and it can be measured in so many different ways. And I'm really pleased to see that almost half of the poll respondents said how important that would be. If we measured, as I said earlier, I think it'll get better because we'll have the tool to tell us what aspects of quality of life specifically need improving and for which groups. So even if equity came in quite low here, and I'm glad at least 1 in 5 chose it, if we have that measurement tool for quality of life, then it can help us provide healthcare much more equitably. As people who know me know, I think it's incredibly important that we get better at monitoring comorbidities at the healthcare system. That will lead to better health outcomes, but it'll also help health systems become more effective and more efficient. And I think that will then help the cause for people living with HIV and for people, who have any of these other conditions, whether or not it's a comorbidity with HIV or not. Because what it really means is a transformation for the health system. It means multidisciplinary teams. It means joint care programs, new care pathways being provided, local co-located services, better referrals, just making everything easier for the patient. So more person or patient centered. So, we have a pretty nice divide here, and it doesn't surprise me much to see the metric at top of though. I'm very, very happy about that, and that's something that we're working hard to do. I think the U equals U is incredibly important because of the stigma against people living with HIV. U equals U really was the game changer that said, now, if you're undetectable, if you're getting the treatment you need, you're untransmissible. And that's just made, as we know and even heard from Josh and others, such a difference on the lives of people living with HIV. So there's really no right answer here. But again, if we're not measuring it, it's going to be really hard at the policy level to get the governments on board. We can go a long way in promoting U equals U. We can be helping to improve equitable healthcare, but we need that health-related quality of life or quality of life instrument being used systematically in every country in the world on a regular basis. So we have a baseline and we can see where things are getting better or where things might even be getting worse. Thanks.
Absolutely. And I really love that response. I think just how we like to share with community that it's important to have a toolbox of options for prevention and care. It's also important to have a toolbox of responses to HIV from a policy and clinical level. So thank you all. Thank you to the panelists and thank you to the audience for responding to that particular polling question and allowing us to use this information to develop a more actionable item. So we have one more polling question, and I'm going to read the options first. I'll share the question, and then we will launch the poll. A, design and deliver patient-centered care in collaboration with people living with HIV. B, empower people living with HIV with information about their care and treatment options. C, implement patient-reported outcome tools in clinic. D, prioritize mental health screenings, referral pathways, and peer support. E, integrate pathways for social support, including advice regarding employment, immigration, housing, etc. And F, develop e-health tools to enable better self-management. Those are our options for the clinical actions. And the question is, which clinic action will make the biggest impact to which clinic action will make the biggest impact to quality of life for people living with HIV? Once again, we will launch the poll, and please respond with your top 2 choices. And once again, the question is, which clinic action will make the biggest impact to quality of life for people living with HIV? Please pick two. We will give a couple of moments for responses to the second question, and then we'll prepare to review the responses and hear a little bit from our panel. We'll give everyone about 20 more seconds to respond to the poll. Once again, please pick your top two responses. So here are our responses. In the lead, we have empower people living with HIV with information about their care and treatment options. Second up, we have integrate pathways for social support, including advice regarding employment, immigration, housing, etc. And then following up in third, we have design and deliver patient-centered care in collaboration with collaboration with people living with HIV. I hear a lot of collaboration here. So I wanted to take a minute to hear a little bit from our panel. Rageshri, you're up first.
Thank you. So really interesting to see the results of this. So we can see that empowering people living with HIV with information about their care and treatment options is top. And I kind of want to link that together with the design and deliver patient-centered care in collaboration as well, although that did come third. Because I think how best to empower people living with HIV with information, how do we deliver the information, what are the best ways of doing that? I think to know these things, you really need to ask the community to work out how we can do this better. And I think when we talk about the involvement of people living with HIV in care, in designing care, we need to make sure it's not just a tick box exercise, and we need to make sure this involvement is meaningful. So looking at who's on our decision-making boards, our funding boards, are people represented? And when we've got people living with HIV, are they from a diverse variety of backgrounds, or are they all from similar backgrounds? So really thinking about involving people, but thinking about who they are and how to do it meaningfully. And I can see also that integrating pathways for social support was voted, and I think I included that in my discussion about the social determinants of health. I think this is so important. We really need to help people with aspects of their lives outside of clinic which impact on their healthcare. So yeah, absolutely great to see that there.
Wonderful and amazing reflections. Thank you so much. And now we'd like to hear a little bit from Mario.
Okay. Very interesting results. And yes, of course, empower people want to know much more about their care. They want to know what their treatment options are. And we have to make sure that they do get this kind of information. So I think this is what came out of the first option was this one. And I think it's something which is strongly felt by people living with HIV. I mean, then, of course, it's very interesting, the one about the integrate pathways for social support, because we know that during the clinical consultations, for example, sometimes our physicians, our doctors don't really know what to do with some information they get from their patients. And so sometimes they're maybe even hesitant to ask too much, because they don't really know what to do with this information. So I think it's very important to try to, let's say, structure some good referral systems. So there must be a good communication with the community, with the territory, and see what's offered over the territory, and be able to not only with all the other community-based organizations over the territory that may be, some may be regarding employment, some may be, providing housing or things like that. And so this could be a way to actually ensure, improve the quality of life of people somehow.
Wonderful. Thank you so much, Mario. Do we have any other responses regarding the results of this poll from any of our other panelists? Well, wonderful. Thank you so much. And thank you to our audience for engaging in this particular activity. And this, again, will help us to prioritize actionable steps to continuing to support people living with HIV in their health-related quality of life. So we are nearing the end of our time together. And once again, I want to thank all of our panelists for your insights and our audience for participating both on social media and here in our interactive sections. At this time, it's been really exciting to come to a consensus and a focus around how we improve the health-related quality of life for people living with HIV. And as we wrap, I want to give an opportunity for a couple of our panelists who have some closing statements and reflections from today's conversation to share with our audience. So first, I would like to pass it over to Susan.
Hi, everyone. Well, this has been an absolutely tremendous session. And thank you so much, everyone who have shared their really important insights. And I also really appreciate the comments from everyone who have taken part and shared their thoughts in the poll. I mean, one thing that's coming across really strongly for me in this conversation has been about the meaningful engagement of people living with HIV and the avoidance of I don't know, like tick box exercise in involvement with us. I mean, we are the experts through our experience, and it's crucially important that healthcare providers listen to us, but also learn from us, and also we need to be actively involved in any decisions about our care. And just to touch on the last poll, I do believe that information is crucially important for everyone living with HIV, so we can make informed decisions about our care, because I very much believe that knowledge is the most empowering thing for us in terms of ensuring good quality of life. Thank you.
Thank you so much, Susan. Knowledge is the most empowering thing for us. Hashtag changing HIV care. Next, we'd like to hear, and finally, from Professor Lazarus.
Thank you so much, and thank you really to all the fellow panelists and everyone who joined us today. I think it's just great that we have a chance after the conference to reflect on important issues, and one of those key issues really is health-related quality of life. I think health-related quality of life is here to stay. It's one of the few positive outcomes of the pandemic. Everyone in the world now knows the importance of quality of life, because as I said earlier, and we know they suffered so much during the pandemic. We need the HIV movement to champion HRQOL for themselves and really for everyone, so that the health system understands that this is an integral part of everyone's health. We have to go back to that WHO definition from 1948 and remember that health is a complete state of physical, mental, and social well-being, not merely the absence of infirmity or disease. Care has been improved over the decades. HIV care has been improved over the decades thanks to people living with HIV. In the beginning of the epidemic, they knew more about how the antiretrovirals were working than the doctors caring for them. And now, as we move into this beyond viral suppression era, they know the importance of HRQOL, and not all doctors and not all governments and policymakers are yet on board. So we heard the importance of developing a metric. We need to make sure that there's a metric in place that goes beyond current UNAIDS and WHO guidance, a metric that will really allow people living with HIV to self-report their health-related quality of life, so it can feed into the clinical practice that will improve their situation, and that will feed into national and global monitoring, so we know how the population of people living with HIV as a whole are doing according to themselves. Thank you.
Wonderful. Thank you so much. So many jewels that you shared with us today, Professor Lazarus. So we're very appreciative of that. If there are any of our other panelists that have closing statements, now's your time. And And if not, I would like to share a huge thank you to all of our esteemed panelists and speakers who shared their work today, and continue to share their insights on how to improve the health-related quality of life for people living with HIV. I would also like to thank Yana Palova from our Ukrainian activists who helped us to capture some of the key insights in IAS 2021. Additionally, I would like to thank our audience for spending time with us today, investing your time in our community of listeners on social media as well. Thank you guys for engaging with us today. And just as a reminder, today's session is recorded and will be made available online for on-demand access. It will also include our Spanish translated version. And so thank you guys once again for all of your help and for engaging us with our post-IAS session around health-related quality of life and unlocking our common health. Once again, my name is PJ Moulton Poole, and it has been a pleasure hosting and sharing space with you on today. Until next time, be safe and have a wonderful rest of the week.